Good afternoon. Welcome back to Grand Rounds. Today we have Elena Swingler talking about antimicrobial stewardship for the infection preventionist. Elena, I'm going to stop sharing my screen and it's all you.
All right. Let me get set up here. Okay, can you all see my slides?
Yes.
Okay, so I will be talking about antimicrobial stewardship for the infection preventionist today. And the objectives for today's presentation are to describe the role of infection prevention in antimicrobial stewardship and to recall the CDC core elements of stewardship and opportunities for nurse application of some of these principles. So before we discuss exactly what infection prevention should know about stewardship, it is important that we understand some fundamentals about antibiotics. So antibiotics are commonly used in healthcare and microbials in general, but they are really a double-edged sword. On the one hand, antimicrobials are considered curative medicines for most infections. You can take a course of antibiotics and be completely cured of that infection, which is great. And modern medicine really does depend on antimicrobials. The most direct example of this is sepsis and septic shock, which is, as you know, a very life-threatening illness that requires attention, which antibiotics are very key to patient survival for that. But then other things as well, such as surgery, transplantation, and oncology. Some of these more advanced medical practices really wouldn't be what they are today without antimicrobials. So certainly modern medicine today, as we know it, wouldn't be possible without antimicrobials. And then on the other hand, however, we have toxicity. So no antibiotic or antimicrobial is without its risks. And many of these antibiotics do have serious, potentially permanent side effects. Allergies as well are a risk, as well as line infections for antibiotics that must be given IV, seal risk, and last but not least, resistance. So along with air pollution and climate change, the World Health Organization names resistance as one of the top 10 global public health threats that's facing humanity. And infections, ranging from simple UTIs to tuberculosis are at risk of becoming kind of untreatable diseases if we keep having, new multi-drug resistant organisms occur. And new drugs are not being developed fast enough as it is today. So there's currently pretty low innovation in the ones that are being developed. So this is considered not to be, keeping up with the resistance that we're seeing. And the problem of antimicrobial resistance as a whole, we saw here in the US, has been worsened by the COVID pandemic. So in 2022, the CDC published this report detailing the impact of COVID on resistance patterns. And you can see in this table here, there's several organisms that we've seen an increased incidence. So several reasons, for this have been proposed, but in general, we're trending up with that. And then the bottom line is that with antimicrobial resistance, we wouldn't have it if we didn't use antimicrobials. So the main driver really is misuse and overuse of antimicrobials. So this slide illustrates exactly how that resistance can happen and become problematic. The first box here, you can see we have lots of bacteria in our body. Some of those bacteria may be resistant to antibiotics. And then the second step is when we take antibiotics, we kill off that bacteria that is susceptible to it, that's causing the illness. And then the other things that are not being killed kind of proliferate and take over. And then at that point, the patient is colonized with an antibiotic-resistant organism. And then not only can that be an issue, but also sometimes bacteria, can transfer their genes to other bacteria and really just kind of compound that problem. So unfortunately, we know that inappropriate antibiotic use is quite prevalent. There's some large studies, particularly in hospitalized patients and long-term care patients, that show very high rates of inappropriate antibiotic use. And there's various reasons for this inappropriate use. Some of them are listed here for you, but just some examples like excessive duration. For example, treating for a pneumonia for 14 days instead of the standard 5-day duration. Or another big one, especially this time of year, is viral respiratory infections. As we know, those do not respond to antibiotics, and yet this does occur. And then this map from the CDC shows community antibiotic prescriptions in 2020. The darker areas are higher use areas. And you can see that Kentucky is one of those darker states. Really, the South has a lot of use, high use, and Kentucky is in general the 5th highest outpatient antibiotic use reported. So at its core, antimicrobial stewardship is just a set of interventions that are coordinated and designed to improve and measure the appropriateness of antimicrobial use. And the way that we improve use is by promoting the selection of the right drug at the right dose, route, and duration. And the major objectives of stewardship are to achieve the best possible clinical outcomes while minimizing adverse events, and of course, limiting selective pressure that puts pressure on various pathogen populations that drive that resistance. So antimicrobial stewardship and infection prevention really go hand in hand. Both disciplines share the common goal of protecting patients from morbidity and mortality that's associated with MDROs and C. difficile infections. Now, the way we go about this is slightly differently. So with stewardship, we're working more upstream, trying to prevent the development of resistance in the first place, or for example, prevent favorable patient conditions for C. difficile to become a problem. And then later down the line, infection prevention certainly helps prevent transmission of those infections. And if an infection is acquired despite all our efforts, the patient really just has to be treated for that infection, and therapeutics are our last line, kind of downstream option to help, save that patient from any complications of that infection. And like I mentioned before, there's not a whole lot of new antibiotics coming down the pipeline, so that just makes our efforts upstream that much more important. So this brings us to the CDC core elements for stewardship. So hospitals, the CDC outlines certain core elements that they have found to be correlated with successful antimicrobial stewardship. And they have these documents that have been adapted to several different settings that you can review here. And CDC acknowledges that there's no one-size-fits-all approach for stewardship, but in general, these elements should guide stewardship efforts. And these have been adopted by various accrediting bodies and regulators. And it's important to know, since infection prevention can help facilities meet some of these core elements. So let's briefly review what each element is, but then I'll go into more detail into the ones that are starred. So hospital leadership commitment is certainly important for a program. Accountability, there should be a leader that's a pharmacist or a physician that's responsible for the success of the program. And then pharmacy expertise is another core element, since pharmacists have the necessary knowledge to help guide appropriate prescribing. And then the last core elements are action, tracking, reporting, and education. So senior leadership support is critical for the success of a stewardship program. Resources such as pharmacists and physician time is needed, but not only that, also support from data analytics is key as well. And infection prevention can really help advocate for expanding stewardship services in this way. Since they're usually a more established program and facilities and already have, the ear of leadership to be able to influence that. Multi-drug resistant organism and C. difficile facility metrics are often used as motivators, to secure resources for stewardship. And infection prevention and stewardship programs should really align their efforts for efficiency to further gain good standing with leadership. So next we have action, and this is really where the rubber hits the road, and where infection prevention can have a big impact by facilitating nurse support of some of these activities. So there's many listed here, but some of them are improving culture technique, diagnostic stewardship, which is essentially not ordering tests that are not necessary, which I'll talk about more on the next slide, such as urine cultures. Improving documentation of allergies, antibiotic reconciliation at transitions of care. So this is making sure patients have accurate medication lists so we know exactly which antibiotics should be continued on transitions of care. And then antibiotic timeouts. So this is essentially, when a provider reassesses the appropriateness of antibiotics at 2 to 3 days. And nurses aren't expected to necessarily give recommendations on, how those antibiotics should be altered or maybe discontinued. Really, the purpose is just to bring awareness to the antibiotics as part of the patient's regimen and just to be reassessed for optimizing that. And then IV to PO switch facilitation is certainly something nurses are in tune with, and standard nurse communication regarding patient status changes to providers. So this is an important one. So for example, if a patient has new onset diarrhea and a status change is reported to the provider, it's really good to have additional information that puts that in context, such as the patient has diarrhea, but they were also, recently started on a lot of laxatives and tube feeds. So giving, all the necessary information during that communication. Okay, so a big stewardship opportunity that is relevant to all healthcare settings is ASB. And the definition of ASB, or asymptomatic bacteriuria, is simply, finding bacteria in the urine without symptoms that are attributable to a UTI, to an actual infection. So UTI symptoms include painful urination, increased urinary frequency, urgency, flank pain, and fever in more severe cases. And antibiotics are not required in most patients with ASB. And this statement has been supported by many, many national and international organizations stating that there's no benefit to treating patients with ASB. Now, it's worth noting that ASB is very common, and there are certain populations that are much higher risk of just having bacteria in their urine. So patients with urinary catheters, almost 100% of the time, will be colonized with something in that catheter. Spinal cord injury patients, elderly females, and patients with diabetes are also more likely to have ASB to begin with. And despite the strong evidence that ASB does not require treatment, 45% of the patients that have ASB do get antibiotics. So here I've listed some common misconceptions about UTIs and urine cultures. So the first one is positive urine cultures equals UTI. I think I talked about this on the last slide, but this is not, a clinical UTI is supposed to be a clinical diagnosis. So simply, a positive urine culture is not enough. Symptoms are required for that diagnosis as well. Positive urinalysis is a good predictor of true infection. This is a misconception because it's actually has a poor predictive value for true infection. Cloudy or malodorous urine is indicative of a UTI. This is a common one you might hear patients say or patient family members say. They think this is indicative of a UTI, but this again does not constitute a symptom of UTI and is usually just dehydration related. Elderly with falls and confusion need a urine culture to rule out UTI. This is a reason for several hospital admissions among the elderly, and the asymptomatic bacteriuria guidelines have actually come out with a specific statement regarding this scenario, stating that if that patient comes in and they are confused or they had a fall, if they're otherwise clinically stable, they don't have signs of sepsis, the patient can be observed off antibiotics, and investigated for other causes, since there's so many other potential reasons for that. And then repeating urine culture is needed after finishing antibiotics. This is not true, and it just increases our risk for finding asymptomatic bacteriuria. And then if we don't treat ASB, it will progress to a UTI. This is a misconception as well. As I've said before, there's no benefit to treating ASB, including this progression to UTI. So switching gears here to another area of stewardship that nurses can have a big role in. So penicillin allergies are the number1 reported antibiotic allergy. 10 to 15% of patients will report an allergy to penicillin, when in fact only 95% of them are not truly allergic. So there's a big disconnect there. And the reason that stewardship programs care about this particular issue is that when we use alternative antibiotics, they're usually less effective, more toxic, unnecessarily broad, and more expensive than if we were to use a penicillin-based antibiotic. And along with that goes, patients with a documented penicillin allergy have high rates of C. difficile infection, MRSA and VRE rates, as well as surgical site infections. Another issue with this is that there's this lingering misconception that if you are allergic to a penicillin, you should not use a cephalosporin, when in fact, new evidence shows there's very low cross-reactivity rate, just around 2%. It does matter which specific cephalosporin you're wanting to use, but in general, being allergic to penicillin doesn't, rule out ever getting a cephalosporin. So let's take a look at a fictional patient case involving allergy histories. So TJ is a 65-year-old male who presents to his primary office with shortness of breath, productive cough, chills. He has several comorbidities. He also has a fever, but otherwise stable, and he has an infiltrate on his chest x-ray. He's diagnosed with community-acquired pneumonia, and the provider decides to start antibiotics. So in his chart, he sees that he has a penicillin allergy without any specified reaction listed. So instead of the provider's go-to, which is amoxicillin clavuline A with azithromycin for pneumonia, instead of that, he prescribes levofloxacin. Now, a couple teaching points here. That unspecified penicillin reaction really should be clarified with the patient. Imagine if the patient said, "Oh, I just had some diarrhea when I took that." That could still be a potential treatment option. And then even if there was a true allergy to penicillin, like anaphylaxis, cephalosporins should still be considered in those cases as well. And the reason we really want to avoid the levofloxacin when possible, there's several FDA box warnings for adverse events that are potentially permanent, such as tendon rupture. There's also higher risk of C. difficile with levofloxacin, and it is unnecessarily broad and can drive gram-negative resistance, as it does have anti-pseudomonal coverage and other gram-negative coverage. So this slide goes over some practical takeaway points for allergy clarification. I won't go through each and every question, but these are some questions you could ask your patient to really get a better sense of their allergy. the point essentially is that when a patient reports an allergy, such as rash, for example, it's always best to press for more details, such as, was it an itching rash? Where was it? How severe was it? Did you have to be hospitalized? And questions like this can be really helpful for providers and pharmacists to use in antibiotic selection. And potentially, if we press further, we may be able to remove that allergy altogether after some additional evaluation. Now we'll talk about tracking, which is the next core element of stewardship programs. So antibiotic use in a hospital can be tracked using the NHSN antibiotic use option. So this is reporting that's integrated into the electronic medical record and allows for benchmarking to other hospitals and units. And infection prevention expertise is really needed here for accurate data submission. And CMS hospital participation, conditions for participation will actually require this antibiotic use option starting in 2024. Besides antibiotic use, which I will talk more about on the next slide, important metrics for this program are also MDRO and C. difficile rates, as those can be surrogates for program performance. So the purpose of the NHSN option is to provide inpatient facilities with risk-adjusted inter and intra-facility use for benchmarking and to trend that antibiotic use over time. Now, when hospitals submit their data electronically, what they get back from NHSN is the SAAR, which is the Standardized Antimicrobial Administration Ratio. So this ratio is essentially observed over predicted antimicrobial days of therapy that's adjusted for patient volume. It's adjusted for patient care location, as well as facility level data. And the way you interpret a SAR value is in that table on the right. So a value of less than 1 means your facility has less than predicted use, and greater than 1 is higher than predicted use. Now, there are several ways that a SAR can be calculated for a facility. All facilities that participate will have at least an overall facility level SAR. And then if the reporting is done in a certain way, you can get even more granular level data, such as unit level, so ICU specific SAR, for example, or antimicrobial groupings, such as broad spectrum versus narrow spectrum antibiotics. Now, a couple of limitations to be aware of with this NHSN antibiotic use option is that the SAR is highly dependent on the accuracy of the data that's reported. So data structures such as unit mapping should be accurately mapped to NHSN to get an accurate result. Otherwise, that SAR is not very useful. Another limitation is that it is not adjusted for illness severity or case mix within a facility. Also, peer comparison is not in real time. So the most recent baseline SAR model we have is based on 2017 data. And then seasonality has been proposed as a limitation. For example, antibiotics such as zithromycin have been known to fluctuate throughout the year and be more used during the winter months for respiratory illnesses, but this is currently not being adjusted for. The SAR alone, however, is not a definitive measure of appropriateness of antibiotic use. It really should just be a piece of the puzzle that should, prompt investigation into appropriateness. So here's a real life example of how one large academic medical center has used a SAR at their facility. So during their daily stewardship antibiotic reviews, they have noticed a couple trends. So they noticed that their patients who were being treated for pneumonia were being started on IV beta-lactams appropriately, but then when they were ready for oral therapy, they were switched to oral fluoroquinolones instead of oral beta-lactams, which are considered narrower and more preferred option. And then for another kind of things that they noticed patterns during their reviews, they saw that patients were being started on ceftriaxone for their UTIs. However, local susceptibility results showed that cefazolin was also a good option for that and is in fact narrower and would be preferred to spare the ceftriaxone. So essentially the stewardship team brought this to the attention of their leadership. They created new guidelines and educated pharmacists and physicians. And then they looked at their SAR data after their intervention. So this graph shows the red arrow is when they kind of did this intervention, updated their guidelines, and disseminated all this information. And then the blue line, which is on the top, represents narrow spectrum beta-lactams. So this is basically those drugs that they were trying to get their providers to use instead of the other options. Sorry about that. And then for the line at the bottom, this is the broad spectrum beta-lactams. So this is what they were trying to avoid. So you can see that line up top increased, and it actually increased above 1. So their SAR was greater than expected. And then, the broad spectrum beta-lactams decreased. So I think the most important point and takeaway here is that a high SAAR is not always a bad thing. So in this case, they saw, yes, their predicted use is above 1, but it is for the narrow spectrum beta-lactams that it is above 1, which really shows that their intervention likely had some impact on that. Okay, so reporting process and outcomes measures is another CDC core element. So these reported process and outcome measures should be reported to prescribers, pharmacists, nurses, and leadership. And the specific information that should be reported is listed here. Antibiotic use obviously is very relevant to stakeholders, whether that's NHSN data or other manually collected antibiotic use data for the facility. Also antibiograms. So the purpose of an antibiogram, which is a snippet is shown on this slide here, is really to show susceptibility patterns of organisms that are isolated from our patients and to inform treatment decisions, empiric treatment decisions. And it can also be somewhat of a report card for a stewardship program. And then C. difficile rates should be reported, as well as results of quality improvement interventions, and local and state health department epidemiology and resistance threat updates should be disseminated since they may impact patient care. Now, the last CDC core element is education. And unfortunately, education alone is not enough to fix all antibiotic use issues that facilities may have. And we know that education is most effective when it's paired with a specific intervention tailored to a specific audience. Infection prevention can really help with this in educating bedside nurses on some of these stewardship principles. And there's many educational resources out there. You don't have to reinvent the wheel when it comes to education on stewardship. There's plenty of flyers, toolkits, patient resources, education for clinicians regarding stewardship on these websites that I've listed here. So in fact, the CDC has Antibiotic Awareness Week, which is at the end of this month. So this is going to be something that at Norton Healthcare will be participating in just to raise awareness about antibiotics. And then lastly, I wanted to put in a plug for CASIC. I know many of you are already aware of CASIC, but it is a local, organization that is meant for helping, Kentucky facilities to improve their antibiotic use. We have some excellent clinical education on the website, but besides that, I think another thing that makes CASIC unique is we do offer free, one-on-one facility consultations that can guide facilities to improve their antibiotic use. So with that, that concludes my presentation. What questions can I answer?
Hey Elena, there was a question in the chat. I put some links in there, but I don't know if you wanted to address verbally further.
Okay, I haven't looked at the chat yet, so just a second. Sorry, I'm having some technical difficulties. No, I don't see a question. Oh, there it is. Okay. Yeah. So the elderly with falls and confusion was addressed in the at least in the 2019 update for ASB by the IDSA. You know, they specifically, talked about this, that patients, whether they're outside the hospital or inside the hospital, there's so many reasons for falls and confusion in an elderly patient that if they're otherwise clinically stable without systemic signs of infection or local signs of infection, then they can be investigated for other causes first, and not just be started empirically on antibiotics just for that reason. But yeah, I would definitely check out those links that Matt sent.
All right, thank you, Elena, so much for the presentation. And we will see everybody next week. Have a good day.
Thank you.